All right, good afternoon, everybody. Welcome to SEVA VentRounds. Today is September 5th, 2023. And today we're gonna talk about a common issue on mechanical ventilation is you want and you don't get. And we're gonna talk a little about trigger issues. This is a common item that we see, and I think that this is one of those that are also showstoppers that you need to recognize. Meaning you should stop walking when you see one of these. In terms of disclosures, there's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. There's my conflicts of interest as well as Rob's outlined there, and your host for today is both Rob Chatburn and myself, Eduardo. The ground rules: please keep your microphone muted. This just makes the recording better. But if you want to make any comments, just put them on the chat. Or at some point, if I ask a question and you want to unmute yourself, please go ahead. But just keep it otherwise muted. We offer CMEs for those that are CCF employees, and there's CRC for anybody in the nation that wants to do this. So all our RTs attending get CRCs. But to verify the respiratory therapy CRC, just we're looking at the chat for your name, as well as there's going to be a little evaluation that comes out at the end here on the chat. Just you click it, fill it within an hour of finishing, and you get your CRC. And we're these are free from us to you because we want to have as much attendance from our respiratory therapy community as we can. So the key SEVA knowledge, as you know, we always start with a simple key rule for all of you to remember as you're reading these waveforms. Waveforms in general in the screen will always show a little bit of abnormalities everywhere. But the key is that you learn to focus your eyes in what the ventilator is controlling. And so in the next waveforms that you're going to see for the first time in a while, I have not put the mode, but I think that just from the waveforms, you're going to be able to recognize the mode. But the point is that if you're controlling the pressure during inspiration, you're going to look at the flow waveform. That's where your eyes will go. The pressure waveform will show abnormalities, but your eyes should go to the flow because that's where what you're looking for. And then if you want to confirm or look for other things, you can then look at the pressure waveform, but focus on the flow waveform. And if you're controlling the flow, which only happens in inspiration, in volume control, then look at the pressure waveform. That's key. And actually, you may see abnormalities in the flow waveform during inspiration, depending where the sensor is, but your eyes should be looking at the pressure waveform. I hope that helps. Rob, any comments or tips here?
Yeah, if you were listening closely, Eduardo said you only control flow during inspiration and volume control. What he didn't say is that expiration is always pressure controlled.
Correct. In the current modes available in the market, I only know of one mode that Ariel Garnero sent to us about this FCV that controls flow during expiration. But other than that, there's none other ventilator that controls flow. Is that correct, Rob?
Yeah, and that's not commercially available yet.
That's right. So these remain dogmas until somebody breaks them. So for now, just keep doing this. Just look at those. All right. So here's the first event, and I'm going to challenge you by looking at this image that is courtesy from Dr. Hernandez Cardenas in the Institute of Respiratory Care in Mexico City. She sent me a series of images. You're going to see images from her here. But the first question is, what is the tag? So acknowledging that you may not be able to set the targeting scheme just by looking at this, but you should be able to set some level of knowledge on what are we controlling. So what do you think the breath control variable is here? There's only two options, volume or pressure. So enter your thoughts on the comment section of the board. Excellent. We start seeing some come in. There you go. So there's absolute agreement amongst the audience that this is pressure control CMB. And granted, you cannot, under these circumstances, talk much about the targeting scheme because there may be other hidden, but at the baseline, at least you know that during inspiration, you're controlling pressure. And we know that you're controlling pressure because if we look at the flow waveform, each one of the flow waveforms is different. And actually on breath number 3, or breath, the third mechanical breath that is present here, you can see that no flow is essentially delivered. In the other ones, each one is different. So that is consistent with a patient that it's on pressure control. Roberto?
Yep, it's all good.
Fabulous. And then CMB means continuous mandatory ventilation. And this is a key SEVA knowledge, which is when we say continuous mandatory ventilation, we mean that all breaths are mandatory. And a breath that is mandatory means that the machine controls either the start or the ending. And so for this breath, we know that it's the patient, or at least it seems that it's a signal from the patient that the ventilator thought that this was the patient because it has this little triangle here. And you can actually see some changes on the flow that we're going to talk in a second. But the last one is a machine triggered. So this is definitely a mandatory breath. And then these two, we suspect they're mandatory because the I time is the same amount of time, and that means that this is likely all I time is set, and that means that the cycling is set by the machine or you. So that's as much as I can say just by looking at these waveforms. However, just for the sake of the audience, this was set point. It was PCCMBS, meaning that the operator would set the pressure, the I time, and the respiratory rate on this patient. Roberto.
Yep. Just to reiterate, a mandatory breath is one where the ventilator either triggers or cycles or both inspiration. And it's only spontaneous if the patient both triggers and cycles inspiration.
Fabulous. All right. I don't see any comments or questions, so we're going to move to the load. And this is this is as good as it gets in terms of load identification. As you know, we usually divide them into inspiration and expiration. So during inspiration, you can read. And we said that if we're controlling pressure, we're going to look at the flow waveform. So if you look at during inspiration, what is the major load? Is it resistive? Is it elastic? Or is it PMOS? And I see some answers start to come in. There seems to be a general agreement that this looks like PMOS. And the rationale for that is that there's a little bit of other hints over here, but you don't see a exponential decay on the flow coming back to baseline, and it becomes even more evident during this breath, the second breath. So I'm going to number them just for the sake of clarity. The mandatory breaths are numbered here. And then the third one, there's not even breath went in, and that's because the patient was doing expiratory effort, as we're going to talk in a second. So for me, it's a little bit hard to say if this is elastic or resistive. I see evidence of PMOS, so I would not be able to say if this is elastic or resistive. So during inspiration, I would say this is PMOS. Is this Adi? Go ahead, Adi.
We have an issue about the third breath because there's patient effort, following which there's a machine breath. So is it a late trigger Or is it the third trigger here?
We're gonna get to that in 1 second, Ari, and I'm gonna call upon you because you actually you're hitting on something. We're almost there, but absolutely, there's evidence of PMOS, so you got that absolutely right. And then during expiration, what do you think is the active the most the load, sorry, during expiration? Is it elastic, resistive, or there's evidence of PMOS? And that rapidly comes from the group as resistive, not restrictive, resistive. So it's taking the time constant is taking a long time to reach baseline, and you can see how long is it taking for this patient to get to baseline. Now, there's usually a little bit of concern when we see this. You can see that there is a very high peak flow, and then it slows down a lot. So there's a component that seems to that the flow decreases rapidly and then goes back to a baseline. Why would that be? What are your thoughts there, Roberto?
What you're seeing there is two distinct time constants, one that's very fast and one that's very slow. The very fast time constant is the high peak flow rapidly going down to the very low flow. And you can see that the area under the curve is very small. So you're ejecting a very small amount of volume. What's happening is you're just exhaling the gas that was compressed in the circuit. It's a small volume. It was compressed in there under relatively high pressure. It comes out rapidly. And then once that's gone, then the only flow is coming from the lungs at a very, very slow rate.
Fabulous. So it's one essential is an artifact from the circuit generating that high peak flow. Is that correct, Rob?
That's it.
Excellent. Fabulous. All righty. So now you can see that, I mean, you cannot see the resistive load during inspiration because there's PMOS, but there is definitely a lot of resistive load during the expiration, and that's the main item. And there's other items. So if we go to the PV discordance, let's go to the trigger. And this one has several abnormalities in terms of trigger. And I'm gonna just enter what you see in terms of trigger. Do you see any trigger that it's early, late, false, or falsified? And Raquel, remember, when you're controlling pressure, you look at the excellent. You got it. So what do you guys think is the trigger items that are sabotaging this poor patient? All right. I'm seeing. Good. So a good amount of options coming here. So let's go one by one. So remember, if we're controlling the pressure, we look at the flow. So let's start with the first one. And this is why it's so important that you look at the flow. If you look at the pressure waveform, you can see that it looks essentially kind of flatty, and you would not make much out of it. But if you come down here and just use the y-axis as a reference line, and you can see that the flow, and I'm gonna make it big for a second for you to see it. You can see how the flow has crossed the baseline really close, around one hand, 10 fingers, 10 little electronic fingers away, okay? And if I go up here, you can see that the pressure, the ventilator triggers 1, 2, 3, 4, 5, 6, 7.5 little hands away. So 2 hands versus 10 hands. So you can see that the patient was actually generating, if you come down and look at the flow. Oh, yes. Sorry. Wrong button there. If you see the flow started here, it crossed baseline, and the ventilator activated all the way over here. So this is a classic delayed or late trigger. It just took a long time for the patient to trigger. And in the setting of increased resistive load, that makes you think about aPEEP. If you see the next one, breath number 2, again, you see the breath crossing probably more or less there, and the ventilator pressurizing all the way over here. So this is another late. And then we keep moving, and then we see this little bumpy bump over here. And some of you recognize that. I see a couple of failed coming out there. And the flow, you can see how it went above the baseline, but it didn't trigger a breath. And then the patient exhaled, said in frustration, exhaled and continued to exhale. And then the machine actually delivered a breath, a mandatory breath, and the patient was not even wanting to breathe. The patient was trying to exhale. So that's why now imagine you're exhaling actively with a lot of effort, and suddenly it pressurizes you. The machine cannot overcome the expiratory force of the patient, and so it doesn't deliver any tidal volume. And then the breath cycles, and it allows the patient to exhale. This is the circuit peak flow, and the patient continues to exhale. So this is this one over here is a failed trigger. Roberto?
Yeah, this is interesting because it shows that expiratory flow crossing 0 is a necessary but not sufficient criterion for triggering inspiration. So if the flow didn't cross 0, then you couldn't flow trigger or pressure trigger. If it does cross 0, then you might be able to flow trigger, but you might not be able to pressure trigger depending on what the pressure trigger threshold was set at, which is apparently what happened here.
Indeed, and you caught that beautifully. I mean, the main issue is that this trigger, and in this ventilator, as Ariel recognized this just by the screen, is a C6 from Hamilton. And what they do is they color this little triangle that I'm going to circle right now, this triangle. They color it according to what is triggering it. So if it's yellow, it's the pressure. If it's pink, it's the flow. And if it's blue, it's an intelligent algorithm that they have to trigger the ventilator, that's called IntelliSync. So in this case, this patient has both a late and failed triggers, which are pretty distressing for this poor individual. So if you thought about this patient and what do you need to adjust, is that, and you think about the work of breathing that the patient is generating, there is a big period of time that the patient is not getting any support as the patient is breathing, or to trigger the breath, or to have a breath delivered to this individual. Thoughts, comments? Adi, does this answer your question that you had?
Yeah, but why did the machine not trigger on the third breath when he inhaled?
Why didn't it? Well, we think that this is because the threshold for delivery, the threshold for that was set for the pressure is not enough for the patient to generate enough pressure change because of the aPEEP.
But look at the flow. I mean, the flow went down significantly.
In which breath are you talking about?
The third breath, the failed breath.
Yeah. Yeah, but it's not a flow trigger. It's a pressure trigger. So the machine is triggered by a threshold on the pressure. And so if you cannot achieve that change in pressure, it will not trigger the breath. Even though it's, as you can see, it's generating a good amount of flow, and if it was on flow trigger, it likely would have triggered that breath at that moment. Actually, in this patient, all the breaths would be definitely not as late if it had been flow triggered.
So I mean, they should have changed into a flow trigger instead of having pressure trigger here.
Yeah, so you should be using a flow trigger, exactly. So Ariel puts the effort is not strong enough to overcome the auto PEEP plus the P sensitivity like in the other breaths. That's correct, Ariel. All righty. Any other questions or comments? I'm looking at the chat and I'm not seeing other. Very good. Ari, can you mute your microphone? Thank you. Very good. So this is the key item for this. I would not go right now into inspiration because the one that you have to deal is with that. The cycle becomes mute under this circumstance. But there is something on expiration, which is the presence of expiratory work. And sometimes it's very hard, at least for me, when you have these prolonged expiratory times to recognize if this is just a prolonged time constant or the patient doing effort, which usually they come together. It's a patient that has increased resistance and continues to do effort. But a manifestation of that, and we have presented several cases in which we have patients that have this prolonged expiration, and then the machine delivers usually a pressure control breath, and it doesn't deliver anything. That's a marker that the patient has activation of the expiratory muscles. So this doesn't take away that you should be touching their belly and examining the patient as you're going through the exam. All righty. Okay.
One more thing, Eduardo.
Yes, sir.
The time constant is reflected not only in the flow waveform, but also in the volume waveform.
Yes.
Sometimes it's easier to see there. In other words, the shape of the volume going up should be the same as the shape of the volume going down. It's the same curve, just flipped around. So what I see there is that the expiratory time constant is way longer than the inspiratory time constant. And that leads me to suggest, could this be a ball valve type obstruction?
It could be, yes. Although, because the patient is doing inspiratory effort, right? So that the patient has like expiratory, excessive dynamic collapse.
Well, that would be the same thing, right? I mean, that's a partial obstruction. You have a different time constant on the exhalation than on the inhalation. So yeah, flow limitation or ball valve or something like that is causing the expiratory time constant to be much longer than the inspiratory one.
I like that.
Inhaled peanut.
Yes, I mean, put inhaled peanut. Well, usually it has to be a movable fist. So yeah, it has to come back and obstruct the airway as you're trying to exhale. The last case that we presented here, and it's recorded in the YouTube channel, is the one with a trach had been repositioned in a patient that pulled it out, and it was back walling against so we could push air in, but when the patient tried to exhale, it would dynamically collapse the airway. So great point.
Rob, I wanted to ask you, I mean, are you suggesting, I mean, I have a difficulty with your proposition. I like the idea about the ball valve, but I cannot agree that the inspiratory resistance is the same as the expiratory resistance.
No, that's what he's
resistance is
saying.
higher.
No, it's not. I didn't say that. You're right.
So therefore, the time constant will be different.
Yes, exactly. That was my point.
That's exactly what he said. So I think that you guys are aligned.
Oh, okay.
All right, good. Now let's put a more contentious waveform. Here comes another one. Also, courtesy from the National Institute of Respiratory Diseases in Mexico. This is a nice waveform. And since I'm gonna just ask you about the tag first. So you have this very nice looking waveform during inspiration. So what do you think is the tag? And I just expect you to at least recognize that it's what's the control variable and the type of breath. Excellent. Good job, Samin. It seems that your auto learn is working appropriately. So yeah, it's PC CMBS, well, CMB, but in this case was S, but I would highlight the same height of the pressure waveform. There is, the flow waveform is different between each one of them. And so without a doubt, this is PC CMBS. And so now I'm gonna ask you, what do you think is the load during inspiration and during expiration? So let's start with inspiration. Adi, you're gonna like this one, I think. All right, so I'm seeing some items. All right, for the sake of time, during inspiration, so remember, because we're controlling pressure, your eyes should be looking at the flow waveform. And what you're trying to see is how fast does it decay to get to baseline, right? And the challenge is if there's PMOS or not. So I'm gonna just highlight a couple of items that may help you as you're making these determinations. And I usually try to look at the waveform and see how pretty it looks. And each one of these flow waveforms look a little bit distinct from each other. Actually, I'm just gonna amplify for a second so you can see it. But you can see that the end inspiratory flow is different from here to this one over here. To this one over here, you can see how the end inspiratory flow is different, all of them. And that is a hint that there is something that is varying. So it would be that the compliance or resistance are varying actively, or it is that there's an issue with PMOS, that it's present throughout the activity. So certainly it tries to decay relatively rapidly. And the inspiratory time looks less than a second. It's probably 1.5 seconds. So if I had to guess, it's probably elastic, which is the normal major item, but there's something in between that it's making an aberrancy, and it's probably PMOS on my eyes. Roberto?
Yeah, that's the only thing that can change that rapidly from breath to breath is PMOS.
Right, so I'm gonna put PMOS as the major one. And then during expiration, you try to see how fast it decays, and obviously you see this inspiratory efforts, I mean, or flow that is going into the patient and comes out. You see this one, and it's probably a little bit better, and it takes a while to decay, but probably around 1.5 seconds, which is still within normal. The same with this one, maybe with this one. So I don't see a prolonged resistive load. So I'm gonna say that it's probably elastic, but there's a lot of noise. It's hard for me to determine it. And when I see those oscillations, you can speculate, but you cannot like firmly say it. And sometimes there's other features that we can do to detect that. So here comes the kicker. What do you think is the main issue with this patient in terms of trigger? So you have PMOS, which means that there's a patient or there's a waveform that looks like PMOS in the flow waveform. So what do you think is the trigger issue here? Ariel recognized that there's no markers for patient trigger breath. So every single breath is triggered by the machine. So Samin is saying trigger is not sensitive enough. Yes, I mean, but how do you call that? Do you call it a failed, a false, a late, an early, a normal? There you go. So people are starting to put, there's a lot of a failed question mark. Yeah, that's how you call it, Philippone, when you, so failed. Alrighty. So let's, then during inspiration, is the machine doing, is there severe work shifting? And this means that the pressure during inspiration is going below baseline, and we don't see that, right? And so I'm gonna cross this one. In terms of under assistant, meaning that the patient is doing very little work and the machine, sorry, which is severe work shifting. So I'm gonna cross that over. And then we have it's either normal or there's over assistance. So meaning the machine is over assisting over the patient, and the patient is doing very little effort because it's being over assisted. And one of the key features when we see or the items of over assistance is the presence of failed triggers. So when you see failed triggers, your brain should be thinking, is this patient over assisted? The same way that, I mean, whenever I see a failed trigger, as you saw in the prior one, it can be resistive, or it could be the presence of over assistance. So I'll just point that out, and I'll show you a little bit more information in a second that will help you make a decision. And then in terms of cycle, none of them are cycled by the patient, so this is dead. And then in expiratory work, I don't really see any expiratory work, so I'm going to say that it's normal. Roberto, disagreements, anger management?
No, I'm completely in agreement.
So because in this hospital, because we have the luck of having it, this doesn't mean that you need it. We just have it, and at the INER they had it, and so they did it, and so we have it. I am showing you now the PMOS for our dear patient in question. So what you have here is the esophageal pressure of the patient, and so every time the patient does effort, you're going to see a negative deflection in the esophageal pressure. And if the patient is doing active expiration, you would see the pressure go above or elevate. I mean, it could be, in this case, it's calibrated at 0, and you can see that it goes down, and then it goes down, and then it goes down. And so the patient is going at its own rhythm. And so this is a breath over here. You can see the flow. You can see the breath here. You can see another breath here. You can see a piece of a breath here. That's why the peak flow did not end up where it should. And you can see another one here. And so there's some oscillations otherwise that look like, I don't know if they're cardiac or what, but they are affecting the flow. So it's more likely oscillation. Yeah, so this patient is going at its own rhythm, independent of what the ventilator is asking the patient to do, completely out of sync. I mean, and the ventilator actually doesn't even know that the patient is trying to trigger. The patient is not, the flow sensitivity on this ventilator is not set in a way that it's detecting the activities from the patient, because this should be triggering a breath if the ventilator was set on the appropriate flow threshold. The same that this one should have triggered, and this one over here. So this just tells me that this is likely a situation in which the flow trigger was not active, or it was set in a pressure trigger, and all these failed triggers, this level of desynchrony was because of that. Roberto?
Yeah, and in this case, it indicates that the ventilatory pattern of CMV is not helping. The patient should be in an IMV type of situation, and because we have, this is a C6 again, it could just be in IMV type 3, which means that as long as the patient has a regular, strong inspiratory effort, they should be getting pressure support breaths. And if for any reason they stop doing it, then the mandatory breaths will come back in. So that's an argument for changing the mode right there.
Yeah, I mean, there's several items to consider here according to your goal, right? So if your goal was safety, and you're looking at these waveforms with this is not this is something that actually the patient is doing effort with the diaphragm and not getting any support. So that's going to lead to potentially fatigue and other items besides sedation and anxiety and whatnot. If your goal is comfort, then you're not achieving that on this mode at all. There's absolutely no synchrony. And in terms of work of breathing, there is actually none of the breaths for this patient is getting an appropriate support. So the ABG may look beautiful, but this patient is doing, it's going out of sync with the ventilator completely. So modes like IMB type 3, for example, or type 2, or the presence of pressure control CSVR, so like NAVA or PAV, in which there's proportionality, and it may help with the triggering issues, may help you better with this group of patients. Or even if you don't have any of these modes, just simple pressure support and bedside titration to achieve tidal volume and appropriate PMOS would be a positive thing. But in this ventilator, they have a lot more functions than that. All righty. Woo. Questions, anger management, disagreements. All right, hearing none, I will, boys, we learned today two very nice cases of failed trigger and delayed and late trigger, in which there was likely an issue with the flow trigger, that they should have been used instead of a pressure trigger. You don't need an esophageal pressure monitor for every patient. It's actually just simply doing a expiratory pressure, expiratory pause may help you detect the presence of PMOS and these failed triggers. So just think about that. There's the CME code for the CCF caregivers, the CRC for the RTs. As usual, send us your waveforms either by Twitter or by email. And actually, this VentRounds page is right now in a pause because we're redoing it. But I thank you all for joining us today, and I hope that you learned something with us. So thank you very much. Have a great day.